In Chapter 18, we will be going over the shoulder. The shoulder joint is an interesting joint because it has a lot of mobility, but it isn't very stable. Many sports use overhead motions, which can subject the shoulder to overuse injuries, and we'll talk more about how that happens later, the mechanics behind that. Movement and stabilization of the shoulder requires coordination of the rotator cuff muscles, the joint capsule, so that's the turtlenecky type ligament structure that holds the joint together, and the scapular stabilizing muscles. There are several actual joints within the shoulder complex. Our true shoulder joint is what we know as the glenohumeral joint. So that's where the humerus meets the scapula and the glenoid fossa. We also have the acromioclavicular joint and the sternoclavicular joints. As far as the anatomy, when it comes to bones and ligaments in the shoulder, the humerus is the upper arm, the clavicle is the collarbone, the scapula is the shoulder blade. So the scapula runs here, here. Everything I'm circling right now is scapula. So that is all scapula. So that's the front side of the shoulder blade. On the scapula, we have two important processes. So processes are places, generally speaking, that muscles or tendons or ligaments attach. So our first one is the acromion process. This is the ledge right on top of your shoulder. So if you put your own hand on top of your shoulder, that ledge you're feeling is the acromion process. If you go about 1 inch down and 1 inch over, you can feel this little nodule on the end of the coracoid process. So that's how we find those spots. Next, we have the sternoclavicular joint. So the clavicle meets the sternum right here. That is the only true joint that holds the entire upper extremity onto the torso. The other ways that the arm is held on is mainly through muscles, or the shoulder blade kind of touches the ribs in the back, but it's not an actual joint back there. The acromioclavicular joint ligaments would be the acromioclavicular ligament, which is right here, the coracoacromial ligament, which is right here, and the coracoclavicular ligament right here. So there are 3 ligaments supporting this acromioclavicular joint, which we'll talk more about later. Our glenohumeral joint ligaments are deep inside the shoulder joint for the most part. So this has been partially dissected away, but we have glenohumeral ligaments here. They don't add a lot of stability to the shoulder, so we don't talk about those a lot in depth, but they do add some stability as far as keeping the shoulder joint together. We also have the subacromial bursa. So that's actually not pictured in this picture, but it exists in this region. So underneath the acromion, so sub or below the acromion, beneath the acromion, and in between the head of the humerus and the acromion process, that subacromial bursa lives in a very small space, so it makes it easy to irritate because of that. As far as muscle and tendon anatomy, starting more superficially, we have the deltoids. So that kind of looks like a sleeve on a t-shirt over here. That's our deltoid muscles. We have 3 sections of the deltoid, anterior, lateral, and posterior, and these all raise the arm. So the more anterior portion of the fibers of the deltoid will raise the arm forward, the middle fibers will raise the arm up, and the posterior fibers raise the arm up and back just a teeny bit. The pec major is right through there, and its main job is horizontal adduction. We're bringing the arm across the chest. You can kind of think of it as giving yourself a hug. The bicep brachii is on the front of the arm, so bicep brachii here. The bicep brachii has 2 heads that kind of come through here in the top, That's why it's called a bicep, because there are two heads, bi is two. And then we have the tricep brachii on the back side of the upper arm. So coming through here, and the tricep brachii has three heads, so that's why it's called the tricep. And the bicep will flex the shoulder and elbow just because of its positioning. If it shortens, this joint can get flexed up, and then if it shortens in this region, this joint can get flexed up. For the tricep, it will extend the shoulder and extend the elbow. And those are our more superficial muscles of the shoulder complex. Next are our deeper muscles that are very important for stabilization of the glenohumeral joint are the rotator cuff muscles. So that's supraspinatus, infraspinatus, teres minor, and subscapularis. We'll often abbreviate these as the sits muscles, so that's why we put them in this order. So the supraspinatus, and infraspinatus, both of those refer to their position for, as far as where they are from the spine of the scapula. It comes right through there. So the supraspinatus is above the scapula. It's superior to the scapula. So the supraspinatus runs through here, and it attaches to the front side of the humerus. So it actually runs under the acromion process. And it will abduct the arm to 45 degrees anterior. So basically, if you bring your arm up and about halfway forward, and then face your thumb down, that would be how we would muscle test that supraspinatus. Our infraspinatus is below the spine of the scapula. So that's our infraspinatus below. It will also wrap all the way around to attach to the front of the shoulder. Because of its positioning, if it shortens, so if it goes this, if it shortens, it's going to cause shoulder external rotation. Another muscle that we'll talk about is the infraspinatus. I'm sorry, we just talked about the infraspinatus. The other muscle we're talking about is the teres minor. So the teres minor isn't labeled on here very well, but the teres minor comes through here, and again it wraps around to attach to the shoulder. Also, because of its positioning, it will cause external rotation of the shoulder if it shortens. Our next muscle is deep inside, so we can't see it from this picture. It would be on the front side or the anterior side of the scapula, so between the scapula and the ribs, and this is called the subscapularis, so it's under the scapula, and it basically underneath, deep inside, will run the kind of the breadth of the shoulder blade. It travels through the armpit actually to come and attach to the same point on the front of the shoulder that the other rotator cuff muscles attach to. And because of its positioning, if it shortens, it causes internal rotation of the shoulder. As far as shoulder injury prevention, proper physical conditioning for a specific sport is key. Especially for baseball, because there's so many shoulder injuries with baseball, a lot of baseball teams have what they call prehab programs. So they're required to come in to do what we would normally use for rehabilitation for their shoulder for prehabilitation, to try to keep them from getting injured. It's a good way to do conditioning for the shoulder, and it actually works very well. We want to strengthen through a full range of motion. So a lot of times we'll do, when somebody's first injured, we'll do shoulder exercises with the elbow down at the side so the shoulder's not being put in any unstable positions. But if we're doing prevention, the shoulder shouldn't necessarily be unstable. So we should be able to be strengthening with the elbow in lots of different positions, with the arm even overhead. We want to focus on rotator cuff muscles and all planes of motions. So a lot of times we will use diagonal motions for this because that gets a lot of planes of motion. We also want to be sure to incorporate scapular stabilizing muscles when we're doing strengthening. So we'll do strengthening for the rhomboids, which are in the mid-back, the trapezius, especially the mid-trapezius, which is in the mid-back, and the lower trapezius, The upper traps are usually pretty strong in most people, and most often they're also hypertonic. So we tend to call up our upper traps a lot because they're stronger than the rest of the traps, and they tend to get called up easily when we're trying to do anything with our scapulas. So usually we're talking more about mid traps and lower traps when we're talking about trying to strengthen specific muscles. Also, the serratus anterior. So this is a muscle that comes as underneath the scapula, and it adds a lot of scapular support as well. So all of these muscles enhance the base of function for the glenohumeral joint because we're controlling the movement of the scapula, because the movement of the scapula and the movement of the glenohumeral joint are interrelated. Warm-up should be used before explosive arm movements are attempted. So, volleyball, you'll start with small hits and move to bigger hits and bouncing the ball off the floor and then eventually serving. In baseball, they'll do short throws, and softball, they'll do short throws, working their way into long throws. Also, collision athletes should be taught to fall properly. So it's best not to foosh or fall on an outstretched hand. We want people to kind of tuck and roll when they're falling. And also wearing appropriate protective equipment. So if a sport requires shoulder pads, then the people who are playing that sport should be wearing appropriate shoulder pads. Throwers should be taught proper mechanics. So there are some different schools of thought when it comes to baseball, at least, as far as pitching, whether or not to mess with somebody's natural throw. But I think it is still important to provide education to younger athletes who are learning how to throw, to be careful with their mechanics so that they're not hurting themselves. And all athletes should practice good posture. When we sit with bad posture, it puts a lot of stress, especially on the anterior shoulder. So we want to try to teach people to sit with good posture. It can also reduce neck pain and headaches as well. As far as assessment and history goes, remember that the information provided here is for informational purposes only. We're going to ask what is the cause of pain? So how did they get hurt? Or what hurts? What is their mechanism of injury? So again, specifically, did they fall, or is it from throwing? Do they have a previous history of shoulder injuries? Where is their location, duration? What is their duration, and what is their intensity of pain? Do they have any crepitus or crunching feelings or numbness? Do they feel any weakness or fatigue? And what provides relief? So for throwers, another question we'll ask is, how many pitches do you throw per game or practice? With littler kids especially, they're starting to limit pitches at a really young age because kids were starting to have so many just really bad overuse injuries even from a very young age. So that's part of why we ask that question, because it has a lot to do with the overuse injuries that can happen. If somebody's having crepitus or the crunching, that's not a good sign. Oftentimes that it can mean arthritis if the person's older, but a lot of times that means there's some kind of joint injury inside the joint, or it can mean that they have a really, really, really irritated tendinopathy or tendinitis. As far as observation, we want to look at a couple of things, both with the shoulder and with the posture. So we want to look and see, is the shoulder elevated or depressed? It's common for the non-dominant shoulder, so we'll say this person's right-handed, so their left shoulder is not non-dominant, to be somewhat elevated. Like for this particular individual, it's slightly elevated, and then the dominant side to be slightly depressed. That's not uncommon. And this is just a small amount, but if somebody was vastly different, then that would give us some information about why something could be bothering them. Part of why he's different is because he's injured that right shoulder as well. He's injured his AC joint. And interestingly on him too, his clavicles are actually different. So this is one clavicle, and then this is the other. So their contours are slightly different. The one clavicle is elevated versus the other. So that's our checking the position and shape of the clavicle. The other thing we'll look for too is just to see if there's a disruption in the clavicle, because sometimes we can actually see the clavicular fractures. We want to look at the acromion process. So in this particular case, this individual is showing us a piano key sign. That's what it is when we see this little step off right here, because he's had probably grade 2, like not a super severe AC sprain there. On the other side looks pretty flat. They look really similar. It's easiest to see these things if the person has their shirt off, if that's possible, or we just want to be able to visualize both shoulders at the same time. We want to look for muscle symmetry. It's actually very common for one-sided athletes like throwing athletes or tennis players or water polo players or volleyball players to have more hypertrophy on their dominant side, because they're using that side an awful lot more. So we'll often see more hypertrophy on the dominant side, including in the back muscles, which is really interesting. We want to do a postural assessment. So we want to check for kyphosis. So that's an increased rounding of the mid-back. We want to look for forward rounded shoulders. The best way we can see this if we're checking for somebody's posture is when somebody has their arms down by their sides, their thumb should be forward. If we are looking at somebody from the front and we primarily see the back of their hand, then most of the time that means that their shoulders are forward rounded. We want to look to see if their ear hole here lines up with their acromion process here. So this particular individual has pretty good posture. They don't seem to have too much of a forward head because their ear is lining up with their acromion process. But as the head moves forward, we tend to see a lot more stress on the neck and shoulders there. Even if somebody's head just moves forward an inch or so, it can make it feel like you're adding several pounds to the head. So it's likely to cause neck pain or headaches. And again, that forward slump posture increases the risk of shoulder injuries in addition to other types of injuries like neck injuries. Oh, and I forgot to mention this. This is a picture of a very swollen shoulder. I would guess this individual either has a clavicle fracture or probably a very nice acromioclavicular sprain under all that swelling. It's very unusual to see a shoulder that's that swollen. So most of the time, the best way to look for swelling in the shoulder is to check the contours of all the bony landmarks, and if you can't see those, then that means that there's an awful lot of swelling in that shoulder. Some other things we'll look for with observation would be scapular elevation. So sometimes instead of both scapulas being equal here on the back, one of them will actually be shifted up. So we might see that one is really equal and the other one will be like up here or something. And that's pretty extreme, but it can be pretty noticeable. We're going to want to look for symmetry, so does the musculature look similar size, and winging. So this particular individual has some winging. So what that means is that while the left shoulder blade or the left scapula is pretty flat on the back, you don't see a lot of indentation here. If you look at the right, then we're getting a lot of lift off. So basically that is the same border of the scapula that was laying flat over here. And we're getting a big divot here underneath the scapula on that side as the person brings their arm forward. So that person is demonstrating to us that they have serratus anterior weakness and that they don't have as much stability in their shoulder as they could. Another thing we'll check for, and again this is best to check with the shirt off, so we'd have women wear sports bra preferentially and or tank top. And basically we're going to watch as the arm is fully abducted, so brought all the way up towards the ear. And we're going to be looking at the difference between the movement of the scapula here and the humerus here. So as the arm moves up for the first little bit or first 30 degrees of motion, the scapula should move half as fast going this way as the humerus does going up into abduction. After that, it's more of a 1-to-1 ratio. If the scapula is moving really quickly, then what can happen is that, well, that shows us first that there's a lot of scapular stabilization weakness. But the other thing that's telling us is that as the arm is coming up and as the scapula is coming up, that it's swinging up too fast and it's allowing more compression between the acromion process and the head of the humerus. So we're going to be more likely to see injuries like impingement with people like this. So that's part of why we look for the scapulohumeral rhythm. And that it's more common for that scapula to move too quickly, and we'll want to strengthen the mid-traps and the rhomboids coming through here to help address that. So we'll do that by doing things like possibly rows or reverse flies or something like that with a light enough weight so we're actually calling up the right muscles. If the scapula moves too slowly, which we don't see as often, it could be a sign of overly tight musculature. So same thing like mid-traps, rhomboids, just pulling on that scapula too hard possibly. And we have ways to stretch and mobilize that tissue. As far as assessment and palpation, we want to start with the bony structures with palpation, and we want to try to do that bilaterally and at the same time if we can. We'll start with the acromion process, or the ledge on top of the shoulder, and then work our way through from there. That's kind of our reference point. And we'll want to palpate the clavicles and the AC joints and the sternoclavicular joints and the spine of the scapula and the top of the humerus to see if there are any tender points or if anything feels like it's feeling different than it should. After that, we'll check their soft tissue structures for point tenderness, guarding, swelling, spasms, lumps, or trigger points. We're more likely to find trigger points, say for instance in the upper traps or levator scapulas versus, say for instance, the bicep. What we will sometimes find is that people are really tender over their rotator cuff tendons or bicep tendons. Those can be tender and really inflamed. We want to be sure to palpate anteriorly and posteriorly and also absorb from both of those positions as well, so we don't miss anything. As far as special tests for the shoulder, we have a lot of range of motion and muscle testing for the shoulder. So with the range of motion, most of the time we'll ask people to try to do active range of motion first, and then if they're having a lot of pain or a lot of difficulty with getting to that active range of motion, we may try to assist them with some passive range of motion or moving them through the motion ourselves. But usually most people can go through the motions on their own. So we would ask them to do flexion, extension, abduction or coming out to the side as high as they can, adduction or crossing their arms in front of them at their hip level, internal and external rotation, and we usually do that with the elbows at the side, and horizontal abduction, so that would be bringing the arms open as wide as you can, and then adduction, horizontal adduction, and that would be giving yourself a hug. So we're looking for both sides to be equal and also pain-free. If they're not pain-free, then we'll make a note of that. For muscle testing, we will be testing the muscles of the shoulder, so those rotator cuff muscles, and the deltoid, and the bicep and the tricep, and the scapular stabilizers. Sometimes we'll also test the pec major and possibly pec minor as well, depending on the person's situation. And I can go over that muscle testing in class. For our special tests, specific special tests, in these pictures we have the top one is a picture of the apprehension test, so right here. Basically this is a test for anterior glenohumeral instability. So this is a test we would do if somebody has dislocated their shoulder possibly, or if we think they may have dislocated their shoulder. Usually if I have an athlete dislocate their shoulder and I either help put them back or the shoulder goes back in on its own, I'm not going to do this test because I know that they dislocated. I use this primarily to be able to tell whether or not they've had some instability or possibly a subluxation. Our positive test here would be pain in the shoulder and a grimace, or you might go to bring them up into that position and they'll say, "Oh, I don't like that position, please stop." So that's the apprehension of that movement that that makes it a positive test. This position is where most people will have a problem with dislocating their shoulder anteriorly. So it's that abducted, externally rotated position that they really don't care for. The other special tests that we're going to look at on this page are for impingement. So of the soft tissue structures, so that would be the like the bursa and the supraspinatus that are in this subacromial space, so the space between the acromion and the head of the humerus. So the first test that we'll do there is the NIRS test. So basically you bring the arm near the ear. And you can do that in full abduction, or sometimes people use full flexion. Honestly, it doesn't, in my opinion, really matter which direction you go, as long as it's just completely up. And that would be pinching the head of the humerus on the acromion process, and if somebody has an inflamed bursa, that could be really irritating. Another test we have here for impingement is the Hawkins-Kennedy test. So we're going to bring the arm up into flexion, bend the elbow and internally rotate it. And when we do that, that's going to cause pain here on top of the shoulder. That is also a test for impingement, possibly a little bit more so for the supraspinatus tendon being impinged, but any of the structures that are irritated in that area could be pinched in this position. So these are positive impingement tests. Starting off with our injury section, we'll be talking about a clavicle fracture. So this is an x-ray of a clavicle fracture. You can see the fracture is in about the middle 1/3 of the clavicle here. So that's a nice big gap right there where the bones should be attached to each other. Our mechanism here is possibly a fouche, which stands for a fall on an outstretched hand. People often get hurt with their shoulder, elbow, or wrist by fouching. So when we fall, we really don't want to reach out our hand if we can help it. Tucking and rolling and protecting the head at the same time is really the more preferable falling position if we have to choose one. Another way that people can get clavicle fracture is a fall on the tip of the shoulder or a direct impact. So I've seen these commonly with rugby and also with cycling. Cyclists oftentimes, because of a crash, they'll go over the handlebars and they'll fall on the tip of their shoulder on the way down because they're trying not to fouche. With rugby or football, again, it's usually just direct impact like a tackle. It's also common in skiing because falls are common in skiing as well. Usually injuries to the fractures to the clavicle are in the middle third, unless there's a specific reason why the impact caused a fracture in a different spot. Most commonly we're going to see those in the middle third. As far as signs, usually the athlete will walk up holding their arm, so they'll want to be supporting that arm with the uninjured arm, because the weight of the upper extremity pulling on that fracture is really painful. When I ask somebody what their pain level is with a clavicle fracture, if they tell me it's lower than a 7, I kind of think they may be lying, or they have a super high pain tolerance. These are usually extremely painful. There are a lot of nerve endings in that area. There's a lot of weight of the arm pulling on it. So these would be the type of injury where I would be probably expecting more severe pain. So maybe even upwards of a 7, 8, or 9. Palpation will reveal pain, swelling, possible deformity, and point tenderness directly over the bone. Our treatment here, we have a couple different options. Sometimes doctors will be able to do what they call a closed reduction, which means that they just try to pop the bone back into place from the outside. And then the person will have to wear a sling and a binder for 4 to 8 weeks. After they come out of the sling, then they can do rehab to strengthen their shoulder muscles. Sometimes these need surgery. I will say that for the individuals that have had surgery for a clavicle fracture, they usually put a plate and screws in. I've had 2 or 3 student athletes that have had this, and only one of them has not damaged their plate and screws. Granted, 2 of them were female rugby players, and they literally just bent their plate tackling. So, it is what it is. Obviously, if somebody has a fracture that's disjointed, it needs to be fixed in some fashion. So there's that. But at the same time, if the person's going to continue in a contact sport, they could damage the surgery as well. Another common shoulder injury is an acromioclavicular sprain, also known as an AC sprain. So this picture is showing us the AC sprain right here. Our mechanism here would be a direct blow to the acromion process, so downward blow here, or the person could possibly have an upward blow in the humerus, so they could land hard on their elbow, say for instance, or the person could foosh or have a fall in an outstretched hand. Our signs here would be, for grade 1, the person would have point tenderness and pain with movement, especially with horizontal adduction, so giving themselves a hug or trying to touch their opposite shoulder is usually the most painful, but they could have some limitations or pain with other movements as well. And they won't have a disruption of their acromioclavicular joint, so the joint will look like the other side except for maybe with a teeny bit of swelling. You won't have that nice step off or piano key sign there. A grade 2 AC sprain, they'll have a tear of the AC ligament with a partial displacement of the lateral end of the clavicle. So this to me looks like it may be more of a grade 3 or maybe a really bad grade 2. Usually the displacement isn't readily apparent at first until the swelling goes down with the more mild grade 2s. The person's going to have pain, point tenderness at that joint, and a decreased range of motion, specifically with abduction, adduction, and horizontal adduction. For a grade 3, they're going to have a rupture of the AC or acromioclavicular and CC or coricoclavicular ligaments with a dislocation of the clavicle. So we'll have the clavicle sitting noticeably higher. Sometimes I can even see it through somebody's shirt. But again, a lot of times it's hard to see when there's swelling present. So we may see it more right when it first happens or after the swelling has gone down. But they will have that gross deformity, especially after the swelling has gone down, pain, loss of function, and instability. A grade 3 AC sprain is what we refer to as a shoulder separation. So a shoulder separation is not the same thing as a shoulder dislocation. A shoulder dislocation refers to the glenohumeral joint. A shoulder separation refers to the AC joint. Our treatment here would be ice and stabilization as needed. So even in a grade 1, sometimes people will feel more comfortable in a sling, and that's fine if that's more comfortable for them. We'll refer to a physician if we think that they have a grade 3 or bad grade 2. Rehab would be range of motion and strengthening once they can tolerate moving. We'll want to, again, do a lot of ice. And if somebody is getting close to return to play, we'll oftentimes use a pad, like a donut pad, so that they're not getting pressure directly on that joint. We'll try to disperse that pressure away from the joint with a donut pad. And an ACE wrap. We can use a large ACE wrap for this. Or there are different types of taping that we can do as well. I personally prefer the ACE wraps. I think that they work a little bit better than doing something like a kinesio tape or a K-tape. But everybody's got their own philosophies on that or own preferences. That's a clinical decision based on somebody's experience. But we'll do that until pain-free range of motion returns. So the person should have pain-free range of motion and not be point tender anymore before they start getting taped or padded for play. This slide is just showing us a good graphic of those grades of sprain. So this one is showing us a grade 1 with some disruption to that, slight disruption to that AC ligament. This is a grade 2 with some more disruption to the AC ligament, so it might be completely torn. This is our grade 3 with a disruption to the AC ligament and the CC ligament right here. And then that top picture on the left is a picture of how that AC separation or sprain could occur. Our next type of injury that is actually pretty rare would be a sternoclavicular sprain. So that's when we get a sprain to the joint where the clavicle meets the sternum right through here. These are not particularly common. I've only seen, I think, 4 or so of them in my career of about 20 years. The cause of these would be an indirect force or blunt trauma. So the first person I ever met who'd had an SC sprain was a water polo player who'd gotten kicked in the clavicle, and she had like a mild grade 2 SC sprain, but she still had swelling even a year later from it. We could see where it was. The other 2 or 3 were actually all rugby players. 2 of them happened in the same game, which was really funny because, again, they're pretty rare. One particular individual had no idea how it happened. The other one was sitting in a long sitting position, so feet out in front of him, reaching for a rugby ball, and somebody fell on his back. And he got a 2nd degree SC sprain, sternoclavicular sprain. So it was a very weird indirect force. And I don't know why falling on the back. It must have just kind of forced his clavicles forward and together, and they didn't have anywhere to go, so it moved forward. So our signs of injury here would be for a grade 1, pain and slight disability. So when they move their arms certain directions, especially if they're reaching across into horizontal adduction, that could hurt. Grade 2 would be pain and some subluxation with deformity. So we may see that that side looks a little different than the other side. So oftentimes it'll look like the bump is a little bit bigger. They could have some swelling and point tenderness and decreased range of motion. Again, oftentimes with that horizontal adduction, but it could be with any type of motion. Grade 2s here are pretty obvious. I mean, it hurts on that spot and it looks different. It looks a little swollen. Grade 3 here, we could get a gross deformity or dislocation. The person could have pain, swelling, and decreased range of motion. If this clavicle dislocates posteriorly on the sternum, that could possibly be life-threatening. So as you see in this picture, this is an anteriorly dislocated clavicle. This is a posteriorly dislocated clavicle. This is your sternum. The things that run through this hole right here are major organs, or like your lungs sit in that general region and kind of lower than your clavicle, but your lungs sit down there. You have major blood vessels and your trachea is right near there. So if that clavicle dislocates posteriorly, we could be at risk for damaging those structures. Our care here would be price. So if the person feels more comfortable in the sling, they can wear it. Remember that joint is the main true joint that holds the upper extremity onto the body, so it can be pretty painful when that joint's getting pulled on. And we'll want to ice that area. We try not to ice the throat itself because that can be a little uncomfortable, so we try to just get the ice directly on that SC joint. They're going to be immobilized for about 3 to 5 weeks in a sling, followed by graded reconditioning, so slowly working up their strengthening with their scapular stabilizers and their rotator cuff and other surrounding shoulder musculature. The next type of injury we will discuss is glenohumeral or GH dislocations. This occurs when the head of the humerus is forced out of the joint. Most commonly, the head of the humerus will go anteriorly and inferiorly. So usually it kind of settles right under the pec major. An anterior dislocation is a result of an anterior force on the shoulder, possibly, forced abduction or pulling up, extension, and external rotation. So again, in that apprehension test position. So with the shoulder, with the arm up into an L position. Occasionally, the dislocation will occur inferiorly, like in this picture. Also, you can get posterior dislocations as well, but those are a lot less common. Posterior dislocation will occur with more of an internal rotation and extension. Signs here would be the head of the humerus might be down and forward or just out of joint. The arm will often be carried in abduction and external rotation, so kind of out to the side, and they're not able to bring it in closer to their side again. The person will have moderate pain and disability as long as the glenohumeral joint is out of position, and they could have a positive apprehension test after it's reduced. Treatment will be price. They'll be in a sling, immobilized until they can see the doctor. To have the shoulder reduced, which means it being put back in place. And even while they're in the sling, we'll want to begin muscle reconditioning. So they can even do isometric exercises while they're in the sling. Use of a sling should continue for at least 1 week, but if they're still feeling unstable or if they're concerned about their shoulder being knocked into by like a rowdy roommate or something like that, then I would ask them to wear it more or longer. And then we can progress to resistance exercises, PREs, as pain allows. Another less serious injury in a lot of ways is shoulder impingement syndrome. This can be pretty painful actually, but it isn't as acute of an injury as a dislocation or something like that. Basically what happens with shoulder impingement is oftentimes it's an overhead athlete or maybe a construction worker or somebody with another type of job where they're having to reach overhead a lot. They'll get a compression of the supraspinatus tendon where it comes through this subacromial space or the subacromial bursa, which is pink in this picture. It's this little guy right here. And also sometimes the bicep tendon can be affected as well. So one of the bicep tendons runs through this space, and that can also get pinched as well. And again, this is, and then so that we have that pinching due to decreased space under the coracoacromial arch. So that could be for any number of reasons. It could be because they're overhead a lot. It could be because of swelling with any of those structures. Sometimes just the anatomy of the individual's acromion process can pinch. So like maybe the acromion is kind of curved forward and it can pinch on that. Or maybe this little coracoid process is also curvy and tends to pinch. So there could be a few different reasons why that can occur or why somebody might be more prone to this. But generally speaking, we see it most commonly in overhead repetitive activities. Our signs here would be diffuse pain. So basically the whole shoulder would hurt. It's not usually something where they can put their finger on the one spot that hurts, but we could have possible pain with palpation of that subacromial space as well. They're going to have decreased strength of their external rotators compared to the internal rotators. Usually the internal rotators are pretty strong anyways, but with somebody like this, the external rotators could get pretty weak. They also might have tightness in the posterior and inferior capsule. So we'll see this when we try to take them into passive range of motion with internal rotation. They'll be able to go into a lot less internal rotation on the injured side versus the non-injured side. And then they can also have positive impingement tests like the Neers and Hawkins-Kennedy that we discussed earlier. Our treatment here would be to restore normal biomechanics in order to maintain that space. So oftentimes we'll do that by strengthening the rotator cuff and the scapular stabilizing muscles, like the mid-traps and the rhomboids and the lower traps, say for instance. We may stretch the joint capsule if that seems to be tight, so we may have them doing some internal rotation stretching. And we may have to modify activity. So we may have to control the frequency and intensity of their throws, say for instance, if they're a throwing athlete, or hits if they're a volleyball player, or mileage if they're a swimmer. Last but not least, as far as our injuries go here, we're going to talk about rotator cuff tears. These are more common in older athletes or older patients, but they can happen with younger people as well. Our mechanism here is that usually this injury involves this supraspinatus tendon. So again, this is the supraspinatus, and that tendon runs under that acromial arch there. So our primary mechanism is usually acute trauma, such as a high velocity rotation, so like a baseball throw possibly. Sometimes people can do this by falling, or if their dog pulls on their leash really hard or something like that. But most often this is from a throw of some sort, or playing tennis possibly, or volleyball. Full tears are most commonly in athletes over 40 with a history of shoulder problems, but younger athletes or even older people who are not athletes can get smaller tears as well. These are actually somewhat common with my older patients who somehow fell or did something that they shouldn't have with their shoulder. Our signs here would be pain with muscle contraction. So if we were to do that empty can test where we were having the person try to abduct their arm when they're about 45 degrees forward to test that supraspinatus, it would be painful. They could have tenderness with palpation and swelling, and loss of strength and function due to pain. Our treatment would be priced for pain. Most of the time these people don't need a sling, but if they're more comfortable that way, it's fine. We'll do some gentle strengthening of the rotator cuff. So if they can't tolerate a progressive resistance, internal or external rotation, say for instance, we may have them doing isometrics to start. And then we'll gradually progress the intensity of activity. These can often be pretty painful, so we want to only progress as their pain tolerance allows. So if you're working with somebody who has a rotator cuff injury, it's best to work isometrics until their pain allows you to begin to do more progressive resistance type exercises. The other thing that I do with rotator cuff tears is that I usually try not to do a lot of overhead activities. So I might avoid something like a regular lat pull down, say for instance, but something like a seated row would be fine. That wouldn't necessarily hurt. Full tears may need surgery, but unless it's a really decent sized tear, most of the time surgeons don't like to operate because the muscle actually most often does better with rehab by itself. Last but not least, in our shoulder lecture, I wanted to give you guys some examples of shoulder rehab exercises. This is absolutely not an exhaustive list of exercises, but some things that we can do would be things like isometrics. So that would be using a wall or using the hand. We could do internal and external rotation, flexion, extension of the shoulder, things like that. Another exercise that's important to do is scapular or postural setting. So this is where we try to draw the scapulas together here to get the mid-traps and rhomboids to contract. The main thing with this is, and part of why I really like this particular picture, is it's showing that the motion is down and together. A lot of people, when you ask them to draw their shoulder blades together or bring their shoulder blades together, they come up and together because those upper traps are pretty strong and the mid traps are not as strong. So we really want to try to, when it comes to somebody who needs that scapular stabilization, we want to try to have our main focus be on that mid back as opposed to the upper back, like the upper traps here. There's nothing wrong with upper traps. We need them to function. It's just that most often that's a muscle that's more easily called up and the person is not weak there. On occasion we'll find people who are, but usually the mid traps and rhomboids are weaker in most individuals. Another type of exercise we could do is we could do a progressive resistance exercise using therabands or very light cables. So this would be an example of external rotation. So the band is coming from this direction and she's pulling it that way. For internal rotation, the band will be coming from the opposite direction. Let's see if I can get that right. So if for internal rotation, the band will be coming from this way and she will be pulling towards her belly. If we do have somebody do internal and external rotation with cables, we need to make sure that the cables are light enough. These muscles are really, really small. So usually I would start an average person off with maybe 5 pounds of resistance here. Definitely preferably less than 10 pounds unless they're really strong. I have had some athletes who I needed to put on cables because bands were way too easy, but the one in particular individual I'm thinking of weighed over 300 pounds and he was only 5'9", and he was just all muscle. So he actually did need pulleys and he did need more weight, but we need to be careful with this because these muscles are so small and they're just not that strong. We can also do proprioception. So an example of this would be using a big exercise ball like this, and we will have the individual place the heel of their hand on the exercise ball, and then they can do, and they want to put a little weight into that. So we want them to put some weight into their hand, not so much that it hurts, but enough so that they are kind of balanced in a way on that hand. And then we can have them do lots of different things. So we could have them do side to side. We can have them do up and down. We could have them do circles. We can have them write the ABCs. All of those things are going to be increasing the difficulty of kind of balancing on that hand. And these shouldn't be painful. Most of the time if people have pain, it's because they're making the motions too big. So I'll just ask them to do a smaller motion. The smaller motion is better for proprioception anyways. If that's too easy, we can progress somebody to doing an exercise that's in a semi-prone position. So this would be a more advanced plank that we would have somebody do who had shoulder pain, but we may be able to have somebody do some proprioception type exercises, possibly leaning on a table or something like that if this is too easy, but this is too hard, for example. So if we're having somebody do planks, we could have them start off just from the hands. The elbows is pretty easy for the shoulder. If that's too easy, we can have them do a plank on a Bosu ball like this. If that's too easy, we could have them rock the Bosu back and forth, say for instance, or we can have them rock it forwards and backwards. We could have them draw ABCs here as well. Another thing we could do is side planks. And then if those are getting too easy, we could go from the hand straight up in the air to then reaching under the body and then reaching back straight up in the air. So that would be more of a rotational plank there, and those get pretty challenging as far as proprioception for the shoulder. If you guys have any questions about rehab exercises or would like to see more or learn more, we can talk about that in class. And that is the end of our shoulder lecture.